My name is Mike Tringale. I'm the Senior Vice President of External Affairs here at the Asthma and Allergy Foundation of America, and we're very glad to have you all at our webinar today. I'm here with Linda Mitchell and Laurel Francoeur, both from Kids with Food Allergies, which is a division of AFA, who are helping me moderate today's webinar. And we're really delighted to honor our two speakers, Dr. David Stukus from Nationwide Children's Hospital in Columbus, Ohio, and Dr. Michael Pistiner from Harvard Vanguard Medical Association and co-founder of AllergyHome.org. And they're here to talk about asthma and food allergies and what parents need to know. So Dr. Mike and Dr. Dave are also co-chairs of the AFA-KFA Medical Advisory Team. Now, this webinar is offered as part of our educational outreach program, and the presenters for our webinar are all doing it as volunteers without any compensation. So on behalf of KFA and AFA, we're very grateful to Dr. Dave and Dr. Mike who are donating their time to be here with us today. So I just have a few housekeeping details before we get to the meat of the matter today. First, today's webinar is made possible through a sponsorship from Mylan Specialty. We're truly grateful for their support of these programs, and we always rely on donors and corporate partners like Mylan to help us fund these kinds of programs to keep bringing you the quality programs you're going to see today. Also, remember that this webinar is just of general nature only, and it is not meant to be medical advice. You really need to consult with your own physicians for any medical advice that you seek regarding food allergies or anaphylaxis or any other medical conditions. And also, as a technical note, we will be recording today's webinar. We have a really large audience with us, and so later in today's webinar we're going to stop and give away some gifts from some of our sponsors like Applegate, Libra Naturals, and Enjoy Life Food. So stick around. You may be one of our winners, and we'll announce those at the end of the webinar. They'll be picked randomly, and we'll contact you to get you your winnings after the webinar. Also after the webinar, you'll see a survey. Please share your impressions with us, and we'll take your feedback. We always take it seriously. It helps us develop the kind of content you're going to see today and topics for future webinars. As our attendance keeps getting bigger and bigger, your feedback gets better and better. And then lastly, before we get started, I want to tell you that we've received many questions about 504 plans, as you can imagine. So we've decided to offer an additional webinar next month specifically on this topic, where our staff member, Laurel Francoeur, will join us on August 26th to answer those kinds of questions. But I also encourage you to go to the archive section of the KFA website to look at a previously recorded webinar on 504 plans that Laurel did for us back in January. So look at that webinar and visit us again on August the 26th for another one. Now I'd like to turn the floor over to our two guest speakers, Dr. Dave and Dr. Mike, to get started. And again, thank you for joining us today. Dr. Dave?
Oh, thank you so much, Mike. It is an absolute pleasure to be here, and I'd like to thank Mike Tringale for moderating today, and to Linda and Laurel for helping to arrange everything, and also for my co-presenter and colleague and friend, Mike Pistiner. I'm really looking forward to today's session. So why don't we just get to it? We hope that this is just going to be a conversational tone. We had lots of great questions ahead of time, and really what we're going to do is just go through the questions that were submitted from our audience and see if we can provide some help. Any comments, Mike, before we get going?
Let's do this.
All right. So if we could go to our first question. Linda, if you're able to advance the slides to, there you go. So the first question is, what kind of information do I need from my child's doctor for the school? So if we can go to the next slide. So the first thing is, I would say, give your doctor plenty of time to fill out anything that you need for the school. This includes prescriptions, making sure that everything is up to date, especially rescue inhalers such as albuterol, self-injectable epinephrine. Make sure that you have enough time to have the prescription sent to your pharmacy, get refills so that you can have them to actually deliver to the school so they have them available. In addition, it's unlikely that you are the only person requesting that your physician sign forms for your child. August is the big rush. My hand cramps up every single year from signing these forms. We love doing it. That's why we're here. We want to help. But it takes a lot of time to sort through everything. So making sure that everything is turned into your physician in a timely manner to allow us time to fill it out, get it back to you or get it back to the school so that communication can occur and everything's ready to go for the start of the school year. In addition, having an up-to-date treatment plan. So this is really pertinent for food allergy and for asthma. Treatment plans come in all shapes and sizes. Most standard ones will have a few key pieces of information, including what's the diagnosis. So if it's a food allergy, what exact foods does your child need to avoid? It will have obviously their name and date of birth on it to identify who it is. What do you do in case of any types of symptoms? So what are the symptoms to watch out for? What are the medications to use, including the doses that need to be administered? And then who's the emergency contact, and what do they do if your child does have a reaction at school? So all these treatment plans really are kind of the same, at least they should be, and should be given every single year with the start of the school year so that it's up to date. Often food allergies may change. Your child may develop new food allergies over time, or some of their previous food allergies may go away. In addition, asthma may worsen over time or may improve over time, so it's important to communicate that with the school every year. Plus, there are new teachers on the other end and new school personnel to consider as well. And then lastly, as you see on the last line, I would strongly recommend and reiterate, do not wait until the first day of school. It happens all the time, and sometimes there's a big crunch from the schools. That can raise a lot of anxiety. It can lead to misunderstanding, miscommunication. So as much as possible, if you can arrange to have all the paperwork and prescriptions filled out ahead of time, I think that would be beneficial for everybody. Any thoughts, Mike?
Yeah, those emergency care plans will need to be legible and something that non-licensed, non-nursing staff are going to understand as well. And so keeping that in mind and screening and taking a look at these when your healthcare providers give them to you, and make sure that there's something that the school staff is going to be able to act on. Some of us in some states live in places where the non-licensed staff can't give antihistamine, but there are delegates who can give epinephrine. Epinephrine is the first-line treatment for anaphylaxis. So these are going to be things that you'll need to take into account when taking a look at some of these and whose hands ultimately they're going to be going into.
Great. So why don't we move on to the next question?
Do I need to provide the school with epinephrine auto-injectors if the school has stock epinephrine? And so this is an issue that's come up more and more now that it's clear that first-time allergic reactions, first-time severe allergic reactions, first-time anaphylaxis occurs in schools. In data collected by Massachusetts school nurses, up to 25% of epinephrine administrations were to people unknown to the school to have a prior allergy. And having some way to treat these people is absolutely imperative because, as we know, prompt treatment with epinephrine is life-saving. And so having epinephrine that is undesignated, that is for someone who the school didn't know had an allergic reaction, is going to be very important. And then having the dosing that's appropriate. So for the case of some of the littler ones, the kids less than 55 pounds, having the junior available, and having the 0.3 milligram epinephrine auto-injectors available for the bigger people is going to be important. Now, stock epinephrine is a bit different than the individualized epinephrine that's coming in prescriptions for the individual patients of healthcare providers. The kids with known allergies still need their own auto-injectors, and they'll need two. In the case that the first either misfired, or in the case that there's a biphasic reaction or a reaction that wasn't adequately taken care of by the first dose while waiting for emergency personnel to come by ambulance and take the child or staff member to the emergency department. So stock epinephrine is different than the epinephrine that's coming in for the individual person with a known allergy. So a long answer to a short question is that you will still need your own epinephrine. Now, what we see here is a map showing where in the country stock auto-injector laws are popping up. This is a big deal, and this is really great that it's got lots of forward momentum and moving, because we really need to be able to get the kids and and adults who are experiencing anaphylaxis to be appropriately treated, because really the only treatment, the first-line treatment that's going to make a difference with anaphylaxis and decrease mortality is going to be that epinephrine.
Okay, so how old does my child need to be to self-carry an epinephrine auto-injector or asthma inhaler at school? So this is a question that I get asked a lot. I'm sure Mike does as well. And, you know, there's no clear-cut black and white answer, unfortunately. I think that it's important that if your child can actually demonstrate proper use while you're at the physician appointment, that would be essential, because that would be an opportunity to correct any type of improper technique or address questions and things like that. And if they're not able to appropriately demonstrate proper use with a training device in a non-threatening environment like at a physician's office when they're feeling well, then we wouldn't be able to expect them to, you know, use the device appropriately in an emergency situation. So I think that's number one. If, you know, I always ask my patients if they can actually show me how to do it, and if they can, then I'll clear them to carry it themselves. I think a lot of my colleagues would say that, you know, there's no cutoff, because developmentally, both mentally and even physically, just to handle the devices, there's a huge range amongst children. I would say ballpark figure, you know, wouldn't start thinking about this till kids are at least 9 years old, but usually it's going to range from anywhere from 9 to 13 years of age before you start considering this. So once your child's around that age, or, you know, starting to think about 4th grade, 5th grade, 6th grade, things like that, then you can start to address it. But one thing I strongly recommend is if they can demonstrate to their healthcare provider and they use it appropriately, then that would be sort of a checklist before thinking about this. Any thoughts on that, Mike?
Yeah, a couple things to throw in there is that there's sometimes, or there is, a slight difference between self-carry and self-administer. In some schools, because of the setup, because of the resources, they do have children self-carry, but without the expectation that they would self-administer. Now, this is sometimes something that some families request, so a kiddo would travel around the school, if that's the way things work in their school day, with potentially a fanny pack or some sort of bag that goes with them. There's upsides and there's downsides. Some kids and families this does not work out for. Some families actually feel a little bit of relief that they know that there is an auto-injector that's available. Some of the things that can be challenging would be if it's forgotten, if it's lost. It should not be the only auto-injector for that child. There should be another one that's available and managed by a school staff member. And then as far as self-administration, where somebody would be expected to self-administer, this is going to be something where in any circumstance in a school, there should be a staff member who is going to ultimately be responsible to be able to recognize and treat anaphylaxis. So even if there's a child who self-carries and is able to self-administer, that should not be the bottom line. Ultimately, a staff member should be able to have access to auto-injector, and not only the one that's on the child, and should be able to recognize and treat anaphylaxis. And so if you hear from a school that because your child has been deemed okay to self-administer, just make sure that that doesn't mean they're the only person who now can. And then things to think about also are that when our children are expected to be by themselves, when they're going to be taking the bus by themselves, staying at the bus stop, going to their friend's house, hanging out there, if there isn't an adult, then we really do need to train them to be able to recognize and self-administer. And perhaps we'll need to come up with alternative plans if we feel that they're developmentally not ready for that. If they can't demonstrate it, then they really shouldn't be alone.
I think those are great points. Thanks, Mike. Okay, I think you're up now. Is that right?
Is a food allergy emergency care plan good enough, or does more need to be done to keep my child safe at school? All right, so having access to epinephrine, having an action plan, these are very important things. But ultimately, prevention strategies, if I could get the next slide up, that would be great. So food allergy management is something that's going to happen in all settings in school at all times, regardless of who the staff member is, regardless of whether or not there's a school nurse, regardless of where the child is in the school building. These food allergy management strategies consist of these two pillars: prevention, preventing an allergic reaction, preventing an exposure to allergen, and emergency preparedness, knowing how to deal with an allergic emergency. And so the school will need to act to prevent accidental exposures. They'll need to avoid. They'll need to know the different ways a child can come in contact through the mouth, potentially through skin exposures, and then ultimately through the mouth, potential mucosal exposures, and perhaps some respiratory exposures with actively cooking food and proteins that can get aerosolized in the air. Staff will need to be able to communicate. They'll need to have access to 911. They'll need access to the school nurse. They'll need access to the information about which child has an allergy and where their action plans are and what they need to do in the emergency protocol. And then there's going to need to be teaching. So we're going to need to act to prevent accidental exposures. As far as emergency preparedness, all staff will need to be prepared to react, to recognize anaphylaxis. Everyone should be able to pick up on a kiddo who's experiencing a severe life-threatening allergy and know their place in the school emergency protocol. Some people in the school will be trained to administer epinephrine. Not only will they know that a child is potentially experiencing anaphylaxis, but then they'll know which are the children that they can give an auto-injector for. And the school nurses will be able to ultimately, especially in the states where many of these stock auto-injector laws are going, they will be able to treat even first-time allergic reactions. But epinephrine will need to be given, and then someone will need to act to activate emergency response, to call 911, to keep the child down. Now, at the point when someone experiences anaphylaxis and is treated with epinephrine, one of the things that we'll want to also do is make sure that in the school that the child isn't then asked to raise and walk to greet the ambulance. It would be best if the child is not vomiting and if the child is not having an airway compromise, trouble breathing, to stay down and to remain laying down, but in cases of vomiting and trouble breathing, then getting comfortable position where their airway wouldn't be compromised will be important. So again, not just having these action plans, but having an entire plan to make them all work with prevention and preparedness will be important in all times, in all settings of the school.
I couldn't agree more. I think that having the plan is the basis and the foundation for having the discussion. So you need the piece of paper, but you also need to have the discussion with the appropriate school personnel. And the other thing I'll add to tie into what I said before is this really should take place before the school year starts. So starting to line these meetings up now might be a good idea to make sure you get all the relevant personnel in the same room.
And in order to pull that off, ultimately staff training will have to be something that the school does. And we will get to this in a bit, but what's beautiful is that now we have state guidelines and we have national guidelines put out by the CDC, so no one has to recreate the wheel. This isn't going to fall on your shoulders anymore. The parents don't need to come up with these prevention strategies and emergency preparedness strategies. They are beautifully laid out in some of these guidelines and in the CDC guidelines, and can be communicated to the schools, and the school nurses are awesome champions to actually train their staff and pull this off.
Okay, how about the next question? What can I do about pets and other allergens or asthma triggers in the classroom and on the school campus? So if we can move to the next slide as well. So this comes up a lot because for anybody with environmental allergies or asthma, they can have a lot of different triggers, which can include things such as outdoor pollen. It can include pet dander, which can be actually carried into the classroom from classmates. So anybody who owns a pet actually carries their pet's dander on their clothing anywhere they go, and this can actually cause symptoms for people who are sitting around them, believe it or not, especially if there are pets in the classroom. So if there are, even rodents in the classroom, such as hamsters and gerbils, or if there are, cats or dogs that are inside the school, those can actually trigger symptoms as well. So there are a lot of different triggers to kind of think about in this environment which can potentially cause symptoms for your child or any student who has asthma and allergies. Communication again. So you're going to hear this theme over and over and over again today. It's just communication with school personnel. Assume that they understand nothing. And don't, I would say that only because the more information you can provide, the better you can communicate and they can hopefully understand and allow them time to ask questions. We'll talk more about that soon. If you can actually provide physician documentation from your child's primary care doctor or, even better, their allergist, that would be very helpful to state exactly what they're allergic to, which would be helpful to know exactly what they're allergic to through appropriate testing if indicated, and what measures need to be taken. So seating accommodations would be reasonable. So you're not asking for a different classroom necessarily, but if you know that your child is having specific symptoms and is due to being seated in a particular place within the classroom or next to certain students who may have other maybe bringing certain exposures into the classroom, it's reasonable to ask for a different seat inside the classroom to hopefully limit their exposure. And then again, just having access to medication. So making sure that everybody's aware of here are the symptoms to watch out for, especially when it comes to asthma. Here are the indications to when to use the rescue inhaler. Where is it located? How often can I use it? How often can I repeat it? And when do I call the emergency contact if things aren't going well? So it's something to consider. It's not something that really comes up quite that often, to be honest with you. It all depends on the situation and the story. One of my more extreme examples was, I'll never forget this, they were in second grade and somebody in the classroom actually wore perfume to school. And one of my patients had pretty severe asthma that wasn't well controlled, and when they were sitting next to this classmate who was wearing perfume, in second grade, once again, it was actually causing respiratory symptoms, and they were having a real hard time, and it was really only occurring in the school setting. And it took some time to try to figure this out, and ultimately it was communication of, here's, my patient's symptoms, their trigger, is there just a different place in the classroom where they can sit? It's not necessarily putting it on the other person to not wear perfume. It's hard to control what others, but it is also helpful to communicate with them and say, hey, if you're willing to limit this type of product, it might actually benefit, a classmate in their health concerns. Any other thoughts, Mike?
Nicely said.
All right. I'm up again. If my child hasn't used their asthma rescue inhaler all summer, do I still need to take one to school? In one word, yes. So asthma is a chronic condition hallmarked by recurrent and reversible episodes of airway constriction. So a lot of times, actually most of the time, people with asthma feel fine. It's very episodic in its presentation, and they may have specific triggers. I'd like to take a moment here to mention something called the back-to-school blues. So asthma emergency room visits and inpatient hospitalizations peak every September and October. It's been like that for decades, and it's across the nation and across the world, really. There's a couple of factors involved with that. One would be increased exposure to viral infections, which can be a big trigger. So kids are in a classroom setting. They're sharing all kinds of different things, lots of germs being swapped, and then they start getting sick, and then they get an upper respiratory infection after being in school for a couple of weeks. Then they start to have asthma symptoms. Another issue that occurs would be rapid changes in the weather in many parts of the country, where you get cold fronts moving through, you can have rainy weather, you can have rapid fluctuations in temperature, which can also trigger asthma. And then also there are outdoor pollen and outdoor mold that can actually trigger it for people with environmental allergies as well. So a lot of children or people with asthma do great in the summertime. The weather is much nicer, they're not sick, they're doing well, but you need to have an albuterol inhaler available during the school year at all times just in case they start to have symptoms, because the sooner you use rescue medicine, the better it works. So there's my answer to that question. Anything you'd like to add, Mike?
No, that's great.
Okay.
All right, any advice about approaching relationships in your school community? Now, this is a very big deal, and relationships when it comes to especially food allergy and anaphylaxis management are important and sometimes tricky and challenging. A major way to approach the issue, and Dave already hammered it home a couple of times, is this communication and education, and communicating the very important needs of people with food allergies. Again, that prevention and preparedness piece, that these are things that ultimately people need to do to take good care of themselves when they have a food allergy. You need to prevent allergic exposure, and the school's going to need to have systems in place for this prevention, and they're also going to need to have systems in place for emergency preparedness. Now, prior to starting school, what's going to be so helpful about this relationship building and about this communication, not only with one or two players, but with the entire school community, is checking in and developing a relationship with your full-time school nurse, if hopefully available, or designee. This is the perfect person to act as a mediator, act as a liaison. They understand the needs of children with food allergies, and at the same time, they understand the school. So from where Dave and I sit, we don't know the size of the cafeteria, if there is a cafeteria. We don't know the vastness of the building, how many floors there are. We don't know where the auto-injectors are potentially kept. We don't know if there is a culture of negativity in the school. No one knows better than the school nurse, and they can then communicate with us and work with us. And so the school nurse is a great person to liaise between healthcare providers and you when it comes to figuring out what an individual kid's needs potentially are, and what the resources of the school are. And then as far as interaction between the families, us, and the other families, the families of kids without food allergies, and the staff and the administration and volunteers, the school nurse is perfectly positioned to be able to help communicate this in general, not necessarily in an individual way. While individual communication is absolutely important, and in many cases very, very appropriate, it's very nice to have this form of communication generalized, because in some cases these relationships can be challenged. In some cases it might be hard for a community that doesn't have an understanding to hear me, a dad of a child with food allergies, try to ask them not to bring in certain things into the classroom for a celebration. It would be much easier communicated by this liaison, by this school nurse who's perfectly positioned. And so that communication and that relationship is going to be really important. Another thing that's so important to communicate is that these things that we ask for in some of the schools with certain policies, hand washing, not bringing in allergens for celebrations into the classroom where the kids also happen to learn and play. These are all things that, like I said before, are not arbitrary. A single scared parent is not coming up with these. These are things that are in guidelines. These are things that are in state guidelines and now federal guidelines. And so now sharing these CDC guidelines with a school, if they are not familiar with them, will be something that will be so helpful, and you won't need to recreate the wheel. And it's not you who's arbitrarily coming up with this. This is something that you can deliver to them. It is what it is, and here it is. And that's very helpful, and it can really help bridge some of these relationships. And then, as I mentioned before, involving your healthcare provider is so important. They really will be able to bridge that gap between your individual child's healthcare needs and the resources of the school. Every school is going to be different. And some schools will have to go at things differently than others, and that's what's cool about those guidelines is they're written loosely enough that they can be implemented in the way that, in a sense, uses the resources of the school without overusing them. And so this way, if there is a K through 8 school, they're going to have a very different interpretation of these guidelines than a K through 5 or a 9 through 12.
Yeah, I just want to emphasize one thing that Mike said. He said it a couple of times now, is the school nurse is so valuable. They want to help. They're desperate to help, and they want to do anything they possibly can, and they are such a great resource. So I think that they're an important part of this whole relationship.
And then as we're switching slides, if your school does not have a school nurse, then advocating for one, talking to local boards, the school boards, and requesting that is something that's very reasonable. If not something that can happen short term, at least putting the thought in the minds of people who do care about kids' ability to learn is going to be really important.
Great. So how do you deal with a teacher who knows nothing about food allergies or asthma? And I'm actually going to amend this a little bit, and Linda, if we could go to the next slide while I do. So I'm going to say, how do you deal with anyone who knows nothing about food allergies or asthma? So this can be grandparents or acquaintances, friends, family members, teachers. When it comes to the school specifically, I would say, again, just schedule a meeting before the school year. So this is something that you don't want to leave until, you know, the first day of school when it's chaotic, or after a month of school or things like that. You want to have a meeting where it's a open environment that you can provide information. So this is where it would be very helpful to provide written documentation from your child's physician that outlines those very specific important pieces of information, such as what the diagnosis is, what are the signs and symptoms of what may occur, exactly what to do if they start to have any types of symptoms with medications and dosing and things like that. So actually give them a copy to look over. If you can provide this ahead of time, that would be even more beneficial, because then it would give them the chance to formulate some questions. Along those lines, I would strongly encourage you to allow them to ask questions. I would even have you ask them, what questions do you have? Because I'm sure they'll have a lot. If this is the first that they've heard of it, imagine when you first received the diagnosis of your child's food allergy or your own food allergy. Think of all the questions that you had, not only at that moment, but that you thought of after the fact. So this really allows a lot of time to process. There's a very steep learning curve, as everybody in the audience is well aware. So having patience and allowing time for questions, as basic as it may be, allow time to sort of validate that and their feelings, and provide information as much as you can, and being very patient with them. So this, again, this part applies to teachers, to family members, anybody that you're dealing with. Ignorance is not always intentional, and a lot of people still don't understand exactly what it means to have a food allergy and what the ramifications of that are. So allowing them time to learn about it is crucial. And then I would recommend revisiting it. Stop back in after a week or 2 weeks and see if new questions have come up or new scenarios. This will give them time to actually see what it's like to help mitigate any risk on a daily basis, and see what scenarios come up. Well, what happens at recess when they're not always within their sight, or during various classes, or going between classrooms, or things like that. Or, unfortunately, if somebody in the school did have any reaction or symptoms, it would allow them time to replay the scenario and review what took place and how best to manage that. So those are some of the tips that I have, but this is, again, it goes back to the whole idea of just communication and allowing time for relaying information.
And just to add to that, this concept that a very small quantity of something that is eaten by others with no worry or concern can actually cause a reaction that can kill somebody is absolutely mind-blowing to some. One way that I like to start that conversation and get people thinking about it is to make an analogy to Superman and kryptonite. It seems that that folks can take it when they start being able to digest it as a superhero, and then understand it. Our kids aren't that much different, especially our kids with food allergies. They're faster than a locomotive. They can't be stopped, but if they come in small contact with their allergen, it can make them sick really fast. So keeping it simple, especially for the doubters out there, and then passing along information that isn't necessarily coming directly from you. In the case of somebody who doubts, In the case of a relative who isn't taking you seriously, getting a third party will be very, very helpful. And then the last point I wanted to make was that, Dave was talking about some of the questions that people ask, and so some of the initial questions from somebody who doesn't know or doesn't understand may feel and sound offensive, but keep in mind that they may just be trying to process this. They're trying to get an awareness that's going to lead to an understanding that they could then support you. And this is going to definitely be seen in children, because sometimes these kids, when they start getting these concepts, they say, wow, I can't believe you can't eat ice cream. I can't believe you can't have pizza. And that at first can sound very bad and very, very mean to a child, but then having these conversations with your own kid, you know what? They may be asking it that way because they really don't understand, and because they really care about you, and they can't understand how you can't have ice cream. And then having conversations with your own child with a potential response, and trying to let them know that maybe this person genuinely cares. These will be important things to think about. All right,
Mike, I think you're. Go ahead, Mike.
All right, I'll take it. Where should I turn if I feel my school is not setting up a good food allergy policy or plan to protect my child? They're not setting up hand washing. There's constant food in the classrooms, and other things that are making things challenging. If we could do the next slide. So we're going to want to get back to the basics that Dave and I have been talking about here. Ultimately, we're going to want to figure out a way that these pillars of food allergy management, prevention, and emergency preparedness will be able to be implemented in this environment with the resources that they have. Again, the presence of a full-time school nurse will really, really help here, or a designee, someone who is taking on these responsibilities, somebody who is going to be able to listen. This is going to be an important thing, is that ultimately having this partnership and being able to communicate the things that aren't working out with this person who can understand and then make change is going to be very important. Now, again, if we need to set up these pillars, recreating the wheel is something we're not going to want to do. Getting the CDC guidelines and state guidelines into the hands of the person who's ultimately going to be the food allergy champion in your school is going to be really important. If that person is having a hard time coordinating things or understanding how things are going, involving your healthcare provider is going to be really important. Seeing if they would be able to reach out to whoever it is who's taking on this responsibility of championing the food allergy in your school will be great. If that person can talk a little bit with them on the telephone about some of the concerns and in a sense act as a liaison to your liaison, then that'll be really important. Potentially, if they could get out there, or perhaps somebody from the healthcare team can get out there and help educate and help give tools, resources, and perhaps education to that school, that would be great. Partnering with all players, administration, nutrition services, custodial services, this will be something that may be really helpful. Now, if there's a concern that the school is unable to provide for prevention and preparedness strategies using the resources that they have, then setting up a 504 and ensuring that these pillars are going to be implemented is going to be really important.
I couldn't have said it better myself. That's great. All right, so here's a tricky one. How should food allergies and asthma be handled on a school bus? So if we can go to the next slide. So once again, same level of communication and training regarding symptoms management, taking the bus driver into account as well, making sure that they have an understanding of what the real risks are with your child, and what to do in case anything happens. This is where what we talked about before, the SelfCarry and self-administration policies would be very helpful, because it may be the case where your child carries their medication with them on the school bus and then turns it into the school nurse once they're there. or they just keep it on them all day and there's a backup at school as well. I would strongly recommend having the backup just in case it gets lost along the way. You can always request seating accommodations. Now, nobody ever wants to be singled out. However, if it is safest for your child to sit in the first row next to the bus driver, that would certainly help mitigate any risk that they would have, as opposed to being on the back of the bus where they could start to have symptoms and nobody would notice it until several minutes have passed by or longer. It's important to talk to the school about what are their policies. Do they allow food to be eaten on the school bus? It's quite possible that this is something that is just not allowed, and that would be much more helpful in reducing the risk for any potential food allergy reactions. But certainly, if it is allowed, talking to the school about perhaps changing their policy, or keeping that in mind for your child's bus routes, so that that one particular bus, there's no food being eaten or exchanged during the bus rides or at any other time. And then I would also recommend talking to your child and being proactive when it comes to bullying. I think this is important in the school setting, and especially on the school bus, because as all of us remember from riding the bus to school, or for those with us with children who are riding the bus now, it can be a different type of atmosphere in a different type of place, and there can sometimes be a pecking order in place that may not come to fruition in other settings. So watching out for the signs, it's unusual and rare for a child to come to their parent and say, hey, Mom and Dad, there's a kid at school who's been picking on me, but things to watch out for, especially if they seem reluctant to go to school. So if they're having subjective complaints of belly pain and headaches that kind of come up out of nowhere and they just don't want to go to school, if they don't want to ride the bus for some reason and they keep preferring that you drive them to school, or they get there through some other mode of transportation, if they seem particularly withdrawn, or even signs of depression and they just don't seem like themselves at any point during the school year and it goes on for prolonged periods of time. Certainly if there's a drop in their grades that is unexpected or unexplained for any other reason, these are all things to think about. And then always talking to the bus driver about what they've noticed and what they have experienced. That can be helpful as well. Anything else, Mike, you can think of?
Just to add, this is a major, major challenge, the transportation services when it comes to school health, because from state to state, from locale to locale, there are differences in who is responsible for bus drivers. In some schools, they are going to be under the responsibility of the actual school, and so training will be something that the school will be able to do for bus drivers. But some bus drivers work for companies that are brought in, and they may have different rules when it comes to training. And so this is something that has been challenging really everywhere. Again, trying to figure out ways for those pillars, prevention and preparedness, even on a school bus where there is a bus driver who is not required to have training. This is going to be tricky, this is going to be challenging, and some people have made some hard choices because of it.
Yeah, and then lastly, if I could just add, alternate transportation sometimes is, what people have to resort to, so that you can just take that risk out of the equation altogether if that's a possibility.
All right. What is the best way to deal with a teen going to school with food allergies? And so now we know that teenagers and young adults are the highest risk group for food allergy-related mortality. That in collections of cases and stories about people who have had fatal and near-fatal anaphylactic reactions, that of those people, about 75% are within the age groups of 12 and 22. And a lot of the thought there is that there may be behavioral things that they're doing that are increasing their mortality. One of which is not having access to auto-injectors and not necessarily implementing the same avoidance strategies that we as parents would choose for them. And so knowing this about this group of kids is going to be really important when dealing with them. Would we be able to move on to the next slide? Now, working with them, from the perspective of parents and then also school staff is going to be so key. They really are going to be spending a lot of time by themselves, and hopefully they're going to be the ones who are going to be championing their own pillars of prevention and preparedness. They're going to be the ones who are really calling the shots on their food allergy management here. Having open communication with them is going to be totally key. If we are people who they can come to, and we are people that they can share their decisions with, then we will ultimately be able to guide them. If they come to us and we punish, if we come to us and we don't listen, they may not come to us, and then they will be making decisions on their own. And we're going to want to partner with them and let them know that we're in it with them. Being able to provide support, because they are going to be in situations, as some studies have shown, where they sometimes compromise their choices because of social pressures, because of peer pressure. One study showed that some children were saying that, or teenagers were saying that they didn't carry their auto-injectors because they were wearing tight-fitting clothing, because they were going to a party, because of other things like that, that to us, their parents, sound ridiculous. But to them, these seemed to be good ideas at the time. And helping them and coaching them and being able to think about some of these circumstances. All right, so you're going to that party tonight. Let's go through a couple things here. What would you do if Mary wants to eat that muffin and then goes to kiss you? These are going to be things that you're going to want to start thinking about, having these conversations with them. They could go into it with a plan. They might give you some ideas that aren't great, but some that are blatantly not safe, and being able to help them have a choice in, obviously, the better to good is going to be really helpful. And then continuously educating them, you know, the reason these cautionary statements are on these labels is because there is a chance that there's allergen. They are for real. This is what the study showed. Get them to understand also, because their awareness is going to be needed for their understanding, and if they are going to need to put themselves in what they deem as socially awkward situations, they need to have a good reason. So they need to be educated, and then they will be empowered. It is awesome to take good care of yourself and to remind them that they are doing a good thing, and to every once in a while give them a high five if that's what you do with your kid, or a pound and explode. Thanks for taking such good care of yourself. You're awesome. These are things that will hopefully encourage them to keep doing the right thing.
The only thing I would add to what Mike said is that you know, for a lot of teenagers, empowerment is fantastic, and I agree 100% with everything that Mike said. But I think something to keep in mind as well is that not everybody deals with the teenage years in the same way, and some of us or some people just had a very hard time with it. It can lead to a lot of emotional anxiety. Pile that on top of having a chronic health condition, and they can really be at risk for having depression and withdrawn behaviors and things like that. So just keeping an eye on all those things, I think, would be important and helpful as well.
And also that reminds me of alcohol and drugs will be something that you're going to want to have this conversation with them about, because it can compromise and will compromise their ability to make right choices. And not only are alcohol and drugs dangerous in themselves, but then you couple that with bad choices and party situation, and it could be life-threatening.
That's a great point. Okay, my child has both food allergies and asthma. And how do you know if they're having an anaphylactic reaction to a food allergy or asthma symptoms? So I actually gave a webinar on this sometime in the last year, and one of my slides was, when in doubt, give epi, and then I repeated that, when in doubt, give epi, give epi, give epi, give epi, give epi, give epi, because epinephrine will treat both. So if there's any doubt whatsoever, the administration of epinephrine will help treat a severe allergic or anaphylactic reaction, or if it's asthma that's causing constriction of the airways inside the lungs, it will also help to relax the airways. And epinephrine is a very effective drug or medication at treating those symptoms of asthma, which is frequently given in the hospital when standard therapies aren't working. So you're not going to hurt them by giving epi. That's the first-line treatment for anaphylaxis. It is not the first-line treatment for asthma, That's generally albuterol or another what we call a short-acting beta agonist or rescue inhaler called Xopenex. But epinephrine will still help asthma. So if you're in doubt, give it. Asthma almost always is just going to be respiratory symptoms. Now, it can be brought on by having a cold or allergies, so you may have a runny, sniffly nose, but it's typically going to be coughing, wheezing, shortness of breath, difficulty breathing, struggling to breathe. So if that's all that's going on without any other symptoms at all, which we'll talk about in a second, and you know that they have asthma, then I think albuterol or the rescue treatment is the rescue inhaler is the first line there. Food allergy, however, it would be very unusual for it just to present with coughing or wheezing and not any other symptoms. This almost always, not 100%, but almost always will involve different types of the body, including the skin. So you could have a rapidly progressing itchy skin rash called hives. You can have swelling of the eyes, the lips, the ears, other body parts as well. There may be vomiting or upset stomach or nausea. They could have, lots of nasal congestion, runny nose, watery eyes, all in addition to wheezing, coughing, difficulty breathing. So typically if there's a combination, that by definition is actually anaphylaxis. So if it's more than one symptom, you give epinephrine. It's anaphylaxis. The timing also for food allergy typically is going to occur close to a meal or snack time. So if you know that it's been hours since they've eaten and they're just out on the playground running around, they're starting to have breathing difficulty without anything else, it's probably a safe assumption that it's asthma till proven otherwise, keeping everything else in mind. But if it happens rapidly within minutes of eating a meal or a snack, then that would argue that it's actually a food allergy reaction. And then lastly, when in doubt, give epi. So there's a lot of misunderstanding about what epinephrine does. Again, it is important to know that it does treat asthma symptoms as well. I do not advocate, nor do others, that you give this first line if it's just asthma. However, if you happen to give it in the setting of asthma, it will actually improve symptoms as well. So you're not going to cause any harm by doing that. But these are some tips to kind of help tease the two apart.
And now passing this information that Dave just said along to the others who are caring for your child will be really important because they might not see it coming from a mile away. And so if there were a food allergy related asthma exacerbation, they may have no concept that epinephrine is what Dave just spoke about. And so reminding them of this, anyone who's caring for your child who has food allergies and asthma, will be really important because now they'll be able to think about it. Now it'll be something that shows up on their radar. And again, then if they can't tease it out, if they're not sure, when in doubt, give epi.
And if I could just do one thing very quickly with our audience members, we'll be able to hear you on this end. So repeat after me. When in doubt, give epi. Very good. All right. Next slide, please.
Are there any special considerations for younger children going to school? So kindergartners, for example. So if we can get the slide up. Yes. So young kids explore their environments with their hands and their mouths. And so there was a study that was looking at potential pesticide exposure in kids, and they watched children and they wanted to see how many times they took their hands or an object and put them in their mouths. Between the age of 2 and 5, they did it 40 times in an hour. And there was a similar study looking at grown-ups, adults in a library where there weren't people around. They knew they were actually being watched, but they wound up putting their hands in their mouths, nose, or eyes 15 times in an hour. And so a skin contact can very easily turn into an oral or mucosal contact and exposure. So that'll be one consideration in the younger age group. Another thing is, just so happens in many kindergartens, there isn't necessarily a cafeteria. Sometimes they are eating in a place where they learn and they play. So this will be something that needs to be taken into account. Another thing is that kids, oftentimes, if there's uncertainty, they may fill the gaps with their own reality that may be way scarier than the real reality. Kind of good examples are being afraid of the dark, the monster under the bed or in the closet. And so food allergy is a good thing here because there is a lot of uncertainty. Even adults have a lot of uncertainty. And the kids can also pick up on the messages and the things that they hear on the television, and they can hear the words life-threatening, severe, and they sometimes hear us talking to a waiter or talking to a doctor, and it can become a very scary thing. So keeping that in mind, having clear communication, and being able to answer their questions when they have them will be very important. And another thing that the school will need to know, and we all should know, is that the younger ones, pre-K, K, they may explain their symptoms in a different way than people are used to. They may say that they have a frog in their mouth. My child, when he experienced his anaphylaxis, he told me he couldn't get the taste out, and started pulling at his tongue, and that was the first sign for us. And so, knowing that the younger ones might not be able to explain their symptoms quite like an older kid or an adult is going to be important to know.
Okay, well, looks like we are almost out of time, so we're going to take one last question here that Mike's going to address, and then we're going to kind of wrap things up. Time sure flies when you're having fun. So, you want to take us home, Mike?
Yeah, all right, let's do it. So, peanut butter in schools. What is the best way to protect my child with peanut allergy? And now, Dave, I know you know what I'm about to say. The pillars. The pillars of food allergy management. It's all about the pillars. If there is a way to guarantee or to get as close as we can to preventing exposure to allergy and knowing that we need to have emergency preparedness, then that should be a policy that'll work. We've heard of certain schools declaring that they are peanut-free or nut-free or peanut and tree nut-free or nut-safe. And now these designations are things that have come up with some controversy because restricting particular allergens doesn't necessarily take care of this prevention and preparedness even for the allergen that we're trying to restrict and for the allergens that other people are allergic to. And so having policies that restrict certain foods may be something that needs to be considered. For example, as I mentioned, in kindergarten where children are learning and playing in the very same environment where they may need to eat because there's no other place in the building they can eat, then considering allergen restriction is something reasonable. Where in a high school where there's a cafeteria and we have kids who are self-managing, having certain restrictions may not be so reasonable. And so these are all things. And then things that we also are going to need to do is define what is it that we are avoiding in these schools. Is it going to include those cautionary statements? Where are these restrictions going to be? Just calling a school peanut-free may not be enough. I would say it won't be enough because you need the pillars. Prevention, preparedness. You need staff training. People are going to need to know how to prevent these accidental exposures, and it's way more than just calling someplace a nut-free environment. And so there's additional information about this if I rush through it too fast. There is this that I wrote called Nut-Free Points to Ponder, and it goes through how to think about it.
I think that's great. If I could just say one last thing about that, it's a very slippery slope, and there's a lot of great arguments on both sides, but there are 8 foods that account for the vast majority of all food allergy reactions. It includes peanut, as well as tree nuts, fish, shellfish, cow's milk, eggs, wheat, and soy. And any one of those could potentially cause a severe life-threatening reaction in those people who are allergic. So I think that it becomes very difficult and challenging when it's not just a child with peanut allergy, but they may also have children with milk allergies or egg allergies, and as you can imagine, this can become controversial and difficult to manage very quickly about where do you stop and what foods do you limit. So it's a challenge. And that bell means we're done.
Yeah, I guess so. And then this one...
That is the sound of the bell for the class, guys. Thank you so much, Dr. Dave, Dr. Mike. Thank you so much for your presentation today. Great information for all of us. And packed full of stuff for us as we just begin our summer trips, but still trying to go back to school. It's very important, folks.
One thing I just wanted to... Oh, I'm sorry. Mike?
Go ahead, Mike.
I just wanted to put a shout out to Dave. And Dave, I don't know if you can hear Eye of the Tiger in the background here. This one's
Oh, we
for
can
you.
all hear Mike. Thank you.
Great. Thanks, everybody, for joining us on this webinar. Now, we have some giveaways to make, so before you all hang up, let me tell you who has won some gifts from our prize sponsors. We have 6 winners. The first 2 winners are winning giveaways from Applegate. That is Amanda Trupa and Carly Sorokman. We will contact you after this event to get you your prizes, so congratulations for that. The 2 other winners from Libre Natural Foods, which is the new home of No Nuttin products, is Janet Marshall and Luz Ruiz. And then our final 2 winners with gifts from Enjoy Life Foods, a leader in allergen-free foods, is Rebecca Hatch and Tracy Bush. So congratulations to you all. We'll be following up with each of you after this in person to make sure you get your gifts. The archive of this webinar, please know, will be on the KFA website in about a week. So visit our archive site. You can see this webinar all over again, including the slides. We'll also be sending out an email to each of you with a link to that archive, so we'll get you to it easily. Make a note in your calendar for August the 12th at 1 o'clock. We're going to be doing another webinar. Charlotte Collins, who's our Vice President of Policy and Programs here at AFA, and Dr. Pistiner again, will be here to talk about the findings from our new report, the 2014 State Honor Roll, which is a look at all the school policies around the country, state to state, and we'll see which states measure up, which states fall behind, which states are just remaining stagnant. There is some new information in that report, so you're going to want to definitely check into that for the school year. And finally, just want to mention that the Kids with Food Allergies is part of the Asthma and Allergy Foundation of America. And if you found today's session valuable and important, we really rely on your volunteer work and on your donations to help keep this webinar series free and available to everybody. And for those of you who are donors, thank you. And for those of you who want to be, thank you again. So we hope to see you later in August. Thank you.